How to interpret ABGs, anion gap, delta gap and examples. What is an ABG? An ABG, or arterial blood gas, measures the pH, PaCO2, PaO2, and HCO3 levels in arterial blood. This test helps assess how well the lungs and kidneys are managing the body's acid-base balance. Basic ABG interpretation. Look at the pH. Normal pH is 7.35 to 7.45. If it's less than 7.35, we have acidemia. If it's greater than 7.45, it's alkalemia. Analyze PaCO2. Normal range is 35 to 45 millimeters of mercury. If it's elevated, think respiratory acidosis. If it's low, think respiratory alkalosis. Check HCO3. Bicarbonate normal range is 22 to 26 milliequivalent/L. A low HCO3 suggests metabolic acidosis, while a high HCO3 indicates metabolic alkalosis. Determine the primary disorder. If the pH and PaCO2 move in opposite directions, it's respiratory. If they move in the same direction, it's metabolic. Assess compensation. If the other parameter, HCO3, in respiratory disorders and PaCO2 in metabolic disorders, is altered, the body is trying to compensate. Understanding the anion gap. The anion gap helps differentiate between different types of metabolic acidosis. The formula is anion gap equals sodium minus chloride plus HCO3. A normal anion gap is typically between 8 to 12 milliequivalent/L. An elevated anion gap suggests unmeasured anions, which could be due to conditions like diabetic ketoacidosis, lactic acidosis, or renal failure. Exploring the delta gap. When the anion gap is elevated, use the delta gap to determine if there's an additional metabolic disorder. The delta gap is calculated as delta gap equals anion gap minus normal anion gap, minus normal HCO3 minus measured HCO3. A delta gap close to zero indicates a pure anion gap metabolic acidosis. A positive delta gap suggests an additional metabolic alkalosis, while a negative delta gap suggests an additional non-anion gap metabolic acidosis. Real-life examples. Example 1. Simple metabolic acidosis with elevated anion gap. ABG values: pH 7.25, PaCO2 30 mm of mercury, HCO3 15 milliequivalent/L, Na plus 140 milliequivalent/L, Cl 100 milliequivalent/L. Interpretation: the pH is low, indicating acidemia. HCO3 is low, pointing to metabolic acidosis. The anion gap is 25 milliequivalent/L, which is elevated, suggesting an anion gap metabolic acidosis. Example 2. Mixed acid-base disorder with delta gap analysis. ABG values: pH 7.38, PaCO2 40 mm of mercury, HCO3 18 milliequivalent/L, Na plus 138 milliequivalent/L, Cl 95 milliequivalent/L. Interpretation: the pH is normal, but HCO3 is low, suggesting metabolic acidosis. The anion gap is 25 milliequivalent/L, which is elevated. The delta gap calculation suggests an additional metabolic alkalosis. A delta gap of 7 milliequivalent/L is positive, which suggests that there is more than just an elevated anion gap metabolic acidosis occurring. The positive delta gap indicates that there is also an element of metabolic alkalosis present. This is because the rise in the anion gap, which usually lowers HCO3, is greater than what would be expected based on the change in bicarbonate alone. This discrepancy suggests that in addition to the anion gap acidosis, there's also a metabolic process that's causing an increase in bicarbonate, indicative of metabolic alkalosis. Example 3. Respiratory acidosis. ABG values: pH 7.30, PaCO2 55 mm of mercury, HCO3 26 milliequivalent/L. Interpretation: the pH is low, indicating acidemia. PaCO2 is elevated, suggesting respiratory acidosis. The normal HCO3 indicates that there is no compensation yet, which can be seen in acute respiratory acidosis due to conditions like COPD exacerbation or opioid overdose. Example 4. Compensated respiratory acidosis. ABG values: pH 7.36, PaCO2 60 mm of mercury, HCO3 34 milliequivalent/L. Interpretation: the pH is near normal but on the acidic side, indicating a compensated disorder. PaCO2 is elevated, pointing to respiratory acidosis. HCO3 is also elevated, showing that the kidneys are compensating, which can be seen in chronic respiratory conditions like COPD. Example 5, respiratory alkalosis. ABG values, pH 7.50, PaCO2 30 mm of mercury, HCO3, 24 milliequivalent/L. Interpretation, the pH is high, indicating alkalemia. PaCO2 is low, suggesting respiratory alkalosis. The normal HCO3 indicates that there is no metabolic compensation yet, which can occur in situations like hyperventilation due to anxiety or pain. Example 6, compensated respiratory alkalosis. ABG values, pH 7.44, PaCO2 28 mm of mercury, HCO3, 20 milliequivalent/L. Interpretation, the pH is within the normal range but on the alkalemic side. PaCO2 is low, indicating respiratory alkalosis. HCO3 is also low, showing renal compensation. This can occur in chronic respiratory alkalosis due to chronic hyperventilation syndromes. Example 7, metabolic alkalosis. ABG values, pH 7.48, PaCO2 46 mm of mercury, HCO3, 30 milliequivalent/L. Interpretation, the pH is high, indicating alkalemia. HCO3 is elevated, pointing to metabolic alkalosis. The elevated PaCO2 indicates respiratory compensation, which can be seen in conditions like vomiting or diuretic use. Example 8, mixed respiratory and metabolic acidosis. ABG values, pH 7.20, PaCO2 55 mm of mercury, HCO3, 16 milliequivalent/L. Interpretation, the pH is very low, indicating severe acidemia. Both PaCO2 and HCO3 are abnormal, with PaCO2 elevated and HCO3 decreased. This suggests a mixed disorder with both respiratory acidosis and metabolic acidosis, which can be seen in severe conditions like cardiopulmonary arrest or severe sepsis. Key takeaways. Always start with the basics, pH, PaCO2, and HCO3-. Use the anion gap to classify metabolic acidosis. Use the delta gap to identify mixed acid-base disorders. Always correlate your findings with the clinical context of the patient. If you loved this, like and hit the subscribe button. We will be uploading more exciting stuff.